Okay, hi everyone. No one's really spoken about it, so I'm going to say just a few words about what is the People's Health Movement. Because I think there's some people here who are having their first contact with us. I mean, there's some old-timers here, apart from us really old-timers. There's some people who have been working with us, and of course there are many who aren't here who've been working with us. So People's Health Movement is really a network organization which was started in the year 2000. So it's a global organization. And we have a presence in somewhere between 70 and 80 countries. And in many countries, we're very small. So we've tried to find out how big we are, where we are. And in about 20 to 25 countries, we are a substantial presence, especially in some countries like in India, which we all aspire to be like in terms of PHM. So in India, they have more than 200 affiliated civil society organizations. So we're not a membership organization, although I'm going to propose at the AGM today that we become a membership organization. So, but globally, we have affiliation of a number of global network organizations like Health Poverty Action, Médicos del Mundo, and others that you might or might not know about, who are affiliated globally, and they're represented on our Global Steering Council. And our Global Steering Council, of which I'm presently co-chair for one last year, and my other co-chair is a young Indian woman. So on the Global Steering Council, we got representation from all the regions of the world. So for example, Mel is the deputy representative for the East and Southern Africa region, and the representative is someone, Penina, who's in Kenya. So each region's got representation, the affiliated networks have got representation, and our global programs have got representation. So we have a few global programs, which I'll mention briefly. One is called Global Health Watch. Global Health Watch is a book which we produce every 3 years. And it's different every 3 years, not just a new edition, it's a new issue. So Global Health Watch is subtitled An Alternative World Health Report. And it's a much more critical analysis of what's going on in global health than you will find from WHO's annual health report. So you will find Global Health Watch on the PHM website. And I hope I've got somewhere. Someone will write on the whiteboard, maybe you and me. Our website, because some of you may not know the website, but on the website you can access and you can download Global Health Watch, including the previous edition. So we've produced 5 of those. So that's one global program. Another global program, something called WHO Watch. And some of you in this room have been on that. And WHO Watch is, we send a few people, the number we can afford. They come mostly from Europe because it's cheapest to get Europe people there, young people who come to WHO during the executive board, which meets in January, February, and to the World Health Assembly in May. So the World Health Assembly is where all 193 governments have representation, including our government. And so our watchers go to the assembly and they watch what's going on. They don't just watch, but they analyze all of the resolutions that are coming forward to the assembly and make a critique of them. So they analyze them, say what we agree with, and what we think is deficient in the resolution, and we produce a kind of let's call it it's a kind of a compilation of all of our comments on all of the resolutions. So anyone who's ever been to the World Health Assembly, it's now paperless, I think, but it used to be the case that each delegation would get a pile of documents this high. And you can be very sure that most of them, except those with enormous delegations, don't read those documents, not least because they interfere with shopping in Geneva. So we provide a service to the delegations. And actually, we have some sympathetic delegations. Used to be Brazil, Thailand, El Salvador, sometimes South Africa, sometimes Ecuador, and a few others that pick up our resolutions and challenge what's going on in the Assembly, because NGOs are given very little time in the Assembly. You're allowed to make a 3-minute statement. So our watchers all get to make a statement on something when there's time for the NGOs to be listened to, by which time many delegates have already left the room. So we go there and it educates ourselves, and it also forms a kind of an advocacy intervention into the Assembly. So that's our second global program. Our third global program is called IPHU, International People's Health University. So that is usually about a 9-day or 8-day course. It can sometimes be shorter and sometimes longer, which we've held in many countries around the world. We must have had maybe between 30 and 40 IPHUs globally, including in South Africa. And Mel convenes something we call SAPU, which is the South African People's Health University. And we've had several of those over the last few years, which have been aimed mainly at community health workers. But the IPHUs in other countries are all different. They're around their issues, but they're all around the political economy of health, the politics of health, and primary health care. So those three are our global programs. And then, of course, in countries, we have work going on. So in South Africa, PHM has chosen to focus, over the last few years, on what we call a People's NHI, which I hope will become clear by the time you finish this workshop. But each country picks up the key issue or issues that they want to campaign on. So in India, for example, where we're huge, they have several issues they're campaigning on. In some other countries, they are campaigning around universal health coverage, particularly in East Africa, because universal health coverage, of which our NHI is supposed to be our homegrown version, is being introduced in many countries. So there are various kinds of campaigns and lobbying and advocacy and so on going on. And if you go onto the PHM website, some of these, not all of these, are actually posted on the website. And you can also, through the website, go into some of the other countries, because they're links to the other countries, and see what PHM Ghana is doing, for example. It's not everything is on the website. We're trying to improve it all the time. So the last thing I'll say is PHM is not an NGO. We are a social movement, which means that most of our efforts are voluntary. We have a tiny secretariat. In South Africa, we've got Tinashe and Annelien, both of whom don't work full-time. And globally, we have the equivalent of about 4 full-time person equivalents. Some in India, Belgium, and South Africa. So we exist on the voluntary efforts of many activists around the world, especially Global Health Watch is written voluntarily by some of the world's leading radical activists in health. They don't even put their names on their chapters. So they don't get any brownie points from their academic institution. This is a collective exercise. So I hope I'm transmitting some of what, this wasn't scheduled, so I apologize to the organizers, but I know there are lots of people in this room who won't know that stuff. So I think you should really go onto our website. The address is up here. And we also have a South African website. So Anneline's reminding me that the country campaigns reside under something we call the Health for All campaign. It's not the same everywhere, as I tried to say. Depends on what the key issues in that particular country are. Although recently we have decided to try to structure that under 6 themes. It doesn't mean a country has to organize under one of those themes, but we've kind of reviewed what's going on. So I hope I can remember all 6. So we have 1 on health systems and access to medicines. We have 1 on gender and health and sexual and reproductive health. We have 1 on environment and extractivism and how they impact on health. We have 1 on food and nutrition, which I co-convene. We have, help me here. Yeah, we have 1 on trade and health.
Conflict?
And the last one, yes, on conflict, violence, and health. So these have recently been set up, or actually some of them have been going for some time, like the trade and health one, and also the one on gender, and we've had some IPHUs around them. So we are now starting to have some of the IPHUs, when we can raise the money, these courses, around some of these issues. And actually there will be one later this year here on health systems and access to medicines. So that's a kind of an overview of what PHM does. Just very finally, we hold assemblies, global events. We've also held some national assemblies, including here. So our global assemblies, we've had so far 4 of them. Our last one was in Bangladesh, and some of you in this room were at it. I think in Bangladesh we had about 1,200 participants from about 80 countries globally. And those who were there can tell you about it. It's quite an energizing experience where you can talk with activists from other parts of the world and get some necessary re-energizing, because as everyone knows, we're living in a very, very difficult global and national political context. I'm not going to go into that, but that is always discussed in both our Global Health Watches and at our assembly. So if you read Global Health Watch, you see the first section of it talks about the global economic and political context, because PHM situates itself within that. We understand that health is political. So we are some of the few remaining people in South Africa who really are active around this. Most of our civil society has been NGOized. So I'm not going to go into that, but that's where we are. So, sorry for that long introduction. I'm now going to give the first half of something that Leslie and I are going to do together. So, it's this first item about why do we need what's called an NHI, or why do we need to reform our health system in South Africa? So very quickly, I'm going to talk about our health situation, the leading cause of disease and death, and their determinants, in other words, the causes and the causes of the causes, and then some of the key challenges, and then Leslie will focus on the health system and its financing and the new policies. So, This is a graph which I'll just try and explain. Apologies to people who already understand it. So this looks at health measured as life expectancy, how long you can expect to live. 50, 55, 60, 65, 70, etc. And along this axis, the wealth of a country measured as GDP per capita, from 500 US dollars per capita all the way up to 50,000. Okay, so people tend to live longest in the richest countries. So if you can read up at the top there, the one in red is Japan. That's where you can expect to live longest. Even though it's not the richest country, the richest is actually the US, the yellow circle, where people don't live as long. And there are all sorts of reasons, but fundamentally it's because the US is much more unequal than Japan. So that people who live less long bring down the average. If you understand what I mean, there's a much bigger gap. So Japan, which I went to very recently, there are a lot of old people and very fit. And in fact, I'm thinking of going to retire there. So I've got more friends. And women live longer than men there. So it's very attractive for people of my age. So, where's South Africa on this? South Africa is here. So, we have a relatively high GDP per capita on average. But our life expectancy is very, very low. So we've had an improvement. We've had an improvement of almost 10 years in life expectancy, mostly as a result, I think everyone agrees, of our antiretroviral treatment program. But increases in life expectancy are now slowing down in South Africa. So we still remain a very poor performer. So we are performing poorly because of our burden of disease, which I'll talk about in a minute, but also because actually our real per capita GDP is somewhere around here, at least for 80% of the population. In other words, 80% of the population are really poor. They're not in the middle income bracket, if you see what I mean. So our inequality is dragging us down as well. So that's, people can ask me questions if they don't understand, or we can talk about it later. So what are the leading causes of what we call premature mortality? Dying really before the age you should die. So HIV and TB remain the biggest, followed by two diseases that affect mainly young children, low respiratory, pneumonia and diarrhea. And then we have the so-called NCDs, non-communicable diseases, these ones. And then we have violence and injury. So we have a very high burden of disease. Actually, I read something recently which says per capita, South Africa has the world's highest burden of disease, which is unsurprising, actually, because we have these 4 epidemics going on simultaneously. HIV, TB, maternal child mortality due to infectious diseases and undernutrition, high prevalence of non-communicable diseases, and high levels, very high levels of violence and injury. So, I just want to I hope this is going to work. I just want to show this very briefly, if I can.
Go to the bottom.
GWHA, parable of the Doctor Development Worker. A baby is floating in the river. No, not Moses. Maybe one of those poor third-world children. So, there's this baby in the river. Fortunately, at that very moment, a doctor happens to pass by. Hello. He jumps into the river and rescues the baby from certain death. Everyone is really happy. But then there's another baby. So the doctor jumps into the river again and rescues him. What a hero he is. Suddenly, there are all these other babies. But our doctor doesn't give up. Save the babies. He gathers a team and thinks big. So big that he becomes world news. No. Our doctor wins prizes and is invited to conferences. He's even invited to the United Nations. He becomes world famous. Isn't that wonderful? Yeah, until someone asks himself, who's throwing those babies in the river? And that is the end.
Where people are suffering, there's a need for medical assistance. But sick children are often a sign of a sick society. Inequality, exploitation, violence, oppression. And we need to tackle those ills through structural measures. A healthy society is a society where economics and politics are in the service of the people, not profit. Here, social movements play an important role. They can make a stand for the rights of the people. In other words, TWHA is doing more than just providing help. We support social movements worldwide in our struggle for the right to health and sovereign development. And here too, we take action in Belgium and Europe for a fair foreign policy. Everybody can join us. That's how we build a counter power to achieve full realization of everybody's right to health worldwide.
Okay, so TWHA, now called Viva Salud, is one of our affiliates of PHM. In fact, they are our financial host for very little money because we don't have much money. So I'm not going to show this one because the other one is better. But the point is, healthcare is of course very, very important. And the NHI, which we're going to be talking about, is primarily focused on health services. But I am trying to make the point in this section of our program that the social determinants of health, the things that make us sick in the first place, are being neglected everywhere and in South Africa. And so PHM insists that any health policy reform, like the NHI, should also address social determinants of health and not just curative care. So, think about HIV. And here's a little buzz group exercise for you. And thanks to Leslie for putting, I think there were 35 slides into this one slide. Thank you, Leslie. So what factors are the immediate causes of HIV? What factors underlie those immediate causes? You can call them intermediate or underlying causes. And what factors underlie the intermediate causes? What are the fundamental determinants of HIV, or the upstream causes? And we use this term upstream because of that river metaphor, which we just showed you. Is everyone with me? Yeah? So buzz next to the person next to you, or two other people. What are the immediate causes of HIV? What are the underlying causes? And what are the upstream causes? The fundamental determinants. Why is it that South Africa, southern African countries, have got much higher HIV prevalence than anywhere else in the world? Much higher. And don't give me the answer because we have sex more often. That's not true. Okay, time's up. So we're going to start with a random group, and then we're going to move the mic around, and if a group has already said something you were going to say, don't repeat it, just say, I agree with blah, blah, whatever.
Where do we start? Yeah. It's going to you.
Yeah. You got me off guard. Like I was saying, for me, this is very, very problematic. I really don't know which one is intermediate and upstream and immediate. Because for me, it was a mess in South Africa. When I was still schooling at the medical school, we called it HTLV 1 and 2. Suddenly, when I was a doctor, I found that there's HIV. And just ran up and rambasted people. So I don't know, because we can talk of violence against women, but it's happening in other countries also. You know, you talk about malnutrition. I don't know whether malnutrition increases or decreases the transmission of HIV. Really, I mean, for me, I'm taking it from my point that we assume that HIV is spread by sex only for not to be complicated and come up with other things. And like we have been saying in the group, that other countries are doing it and probably are doing it less than them because they say we drink alcohol more. So I'm getting a little bit confused, really. Then the other factors, like Botswana started before us, but they still had a crisis, even though we started later. So I'm a little bit confused about studying the drugs early. Did it help? And why sub-Sahara? That's my real question. So this question, I think I'm going to get some answers, because right now for me, I have so many, the political issues that were said, I don't want to go deeper into it about HIV causing AIDS and what was syndrome, whatever. I'm not going to get into it. I might be in problem. So somehow, I think I'm just going to get answers. But my colleague here from Mozambique, I think she has different challenges. So maybe we can listen to what she said.
Okay, anyone in the group want to add? And it would be useful actually when people speak, just to say your name, so that during the course of the day, we get to know each other.
Okay. Once again, my name is Lesoron Tutang, GP, a medical officer in the Northwest.
Do others want to add in that group?
My name is Violeta. My name is Violeta. So, me, I was saying I don't know about South Africa, but I can speak our experience and can be similar. In my country, we have many issues. My English is bad, so. In my country, we have many issues. First of all, it's about the lacking of information. We can, many people are having HIV because they don't have information about how to prevent. And we have also things like about our culture. We had another social practice we call kuchinga. When my husband died, I must sleep with the brother of my husband. It's think about cultural issue. So many people was getting infected because that issue. And many people was working here in South Africa, and they was going to Mozambique with the HIV. And me, if my husband died, I must sleep with his brother. So sometimes I'm infected, I infected his brother or his relative. Right. And also, I hear, I don't know if it's true or no, many people was coming from South Africa to Mozambique, which TB was dying because here was not receiving, like, I don't know how to call it, but they were saying in South Africa there is no like treatment for TB, so they was running to Mozambique to receive it. And another issue can be the politics of the country. if the country don't have good politics, many people can be infected and can die. So if we want to analyze things for HIV, there is too much cases involved.
Lots of causes. Anything to add, Leanne?
Yeah. Just to add on what she said, it's Lesotho Ntutang again. She talked about the healthcare system in Mozambique that is lagging behind, and probably is one of the contributing factors because people are not suppressed. You is not equal to you in Mozambique in most of the case.
Okay, so that group has raised, as I understand it, some cultural and behavioral factors, yes? And the issue of migrant workers. Good, let's just keep that in mind. Pass the mic back, please.
I'm Siamtanda Dastile. So the cause which we have is unemployment. Since we have a lack of employment in South Africa, people must pay rent, people must eat. So people are forced to prostitute because young people, they are having sugar daddies because they cannot even afford their school fees. So employment, it's a huge one because it makes people to become prostitutes. And then because of in South Africa, public resources are mainly with people who are not, how can I name it? It's mainly with people who are not in need of those public resources. So by means of saying that is that the way of creating jobs, the land, the public resources are with people who are not using those resources for the majority to benefit. So by means of job creation.
Anyone want to add from that group?
My name is Ngomeka Sokoi. The other thing I think it's a cause, it's a lack of understanding. People, they don't understand. Where I come from at Tulbach, the people don't want to understand what is happening outside there. If they go to the clinic and the nurses told him that you are HIV infected, they didn't understand. They just say, no, it's a lie. And they go and spread. So this is the other thing that causes the spread of HIV and AIDS.
Okay, good. So you have added a bit more to what you might call the behavioral side of things. You're saying people as, it's Violetta, is it? Oh, Violetta. As Violetta said, there is ignorance or lack of understanding, or people don't want to understand. And you've raised the issue, which is in a way a more fundamental issue. You're saying people are unemployed and they resort to risky sex to earn money. And you even mentioned sugar daddies. Okay, can you pass it along?
So we spoke about...
Name?
Oh, Simone Cupido from Chisimani. So our group basically spoke about predatory intergenerational sex. We focused on the fact that contraction is mostly between women between the age of 15 and 25. And so we recognize there is a power imbalance and inequality in that sort of situation. And we think that that's the sort of upstream causes.
Very good. So it's elaborating on the point of sugar daddies.
Another thing that we also said is that even in relationships that are not necessarily intergenerational, but a lot of women also find it difficult to negotiate condom use. So the autonomy to actually say, I want to have protected sex is limited in those relationships, which is obviously a factor of patriarchy and, yeah.
She's Pindile.
Oh, sorry.
And I am Bobby from, unfortunately, we from the same organization, Chisimani.
More fortunately.
Oh, sorry. I'm saying unfortunately because diversity must be promoted. We spoke about a growing tendency, dangerous, of alcohol abuse amongst the young people, which leads to recklessness. So even if they've got access, they've got the means, so the issue of recklessness. So you get them from middle class families and there's a lot of socializing that has got no control and is growing.
Okay, great. So you've talked again about another behavioral factor, reckless behavior or unprotected sex, which alcohol might fuel. And you've also elaborated on some of the more fundamental causes, apart from power imbalances between different ages and genders. You talk about gender power in respect of sex. Yeah? Good. Can you pass it forward?
Okay, so we
Are you by yourself, Sinesifo? Okay.
I'm happy to pass the microphone.
No, it's fine. Carry on.
Our group, we touched on most of those issues, but we wanted to add the political issues. So with political denialism in the era of our President Thabo Mbeki, we think it also contributed to the rise of the epidemic. And then also, we actually looked at it backwards. So we looked at what actually has now brought the levels of HIV transmission down, and we were looking at things like it's become central political agenda, though most of the funding is from donors and it's from a global level, but it's become a political agenda. But also there have been policy adjustments as well on an upstream level, trying to curb the transmission in terms of like mother to child transmission, and it just also because of the money that is funding HIV research and availability of ARVs in especially local clinics and hospitals, we've seen that there's been a turnaround. So we would say then, in reverse, that there's been a lack of resources that is upstream. So lack of resources, it hasn't been central to the agenda. There's been political denialism. Yeah, I think they'll add.
Yes, I am Russell. I think this to add on to my colleague here, we also spoke about the beliefs out there, the perceptions out there. And even there's one misconception there, if what's happening out there has been, people are actually believe that you sleep with a virgin, you might be cured. So that's one of the misconceptions there. So.
Okay, I'm Jobo. One thing also that comes up is the fact that if a person maybe is HIV, his understanding will be saying, I got this there. So if I'm engaging in sex without a condom, that's a good thing because he's now going, I don't know whether it's revenge, something like that. If I'm HIV positive, I got it where I do not know. So for me, instead of protecting myself, I want the other person to have it just like me. Yeah, something like that is happening very much. Yeah, thanks.
Since we're all saying something, just a lack of adequate counseling services, which leads to people defaulting on ARV treatment, and then which leads to further spreading of the disease.
Okay, great. So you've added more still in your group. Lack of counseling. So again, it contributes to, I suppose, this reduced awareness of both how the disease is caused and how you've got to continue taking your treatment and so on. So it's kind of, I'd put it in the behavioral kind of group. But you also raise an important, but if I understand you, Sinisipo, and I think I do because I strongly believe the same, namely that the attention in combating HIV has been almost wholly devoted to new treatments and very little attention to some of the underlying determinants of the problem in research and in discourse and in so on. Okay.
My name is Isaac, and some of the things have been mentioned by other groups, but two things from our group, and I'll give to my colleague. I think there is a one issue that we tend to run away or tend to forget. The issue of when you are being explained to you that you are HIV positive in a clinic or in where you have been tested, there is what we call treatment tracer. People will understand from TAC. Treatment tracer is a component where you explain to a person that you contracted HIV, and this is what the virus is gonna do to your body, and you explain thorough to that particular person. That's what we call HIV life cycle. If we go to that information and explain very well through that cycle of HIV, a person will understand that I have to exactly protect someone else not to infect HIV, because I know exactly how HIV is going to decrease my CD4 count and make me sick and other stuff. Because you'll go to the clinic and the counselor will tell you that you're HIV positive, your CD4 count is down, and you'll start ARVs. So there's different things that has been told to you. Remember that there's HIV, there's CD4 count, there's ARVs. So you don't get that proper explanation being explained to you thorough so that you can understand. And the issue of people knows exactly. There are information that are given to people each and every day, everywhere you go. But we tend not to. We have that issue of ignorance. We don't want to, we know, but we don't want to practice it, or we don't want to put it in practice or do it. Because if we are talking about HIV, causes of HIV, all those things that have been mentioned, it's things that are happening in our communities. But we can prevent them, but we always say, if I don't do it, I always don't do it. That's me. And someone will always say, take care of Isaac, or someone will come and risk me.
Thank you. I think, Nadira Munshi from PSI. One of the things I want to add is that I think also access to proper treatment. So if you're looking into mother-to-child transmission, access to cheap medical or affordable medical care, drugs, but also how the research that goes into researching HIV/AIDS, who's doing it, and for what reasons. Is it corporate greed, or what's at stake?
Great. Okay, so you've talked even more detail about the behavioral, but also about some of the, I suppose, the access to and attitude of health services.
Many things we've spoken about have been covered. I think to reiterate, we spoke about, I guess, the vulnerability of women and girls within the context of the epidemic as a result of their inability to access healthcare or to feel safe in accessing health services. We also spoke about stigma as another potential, suppose that links into cultural and behavioral issues, but is another thing that stops people from accessing services. Was there anything else we...
Yeah, in additions, I think education is the key. We spoke about educating the community, educating our people, because once you've been educated about whatever, you have to be aware what is the next step in any diseases that you have. Another thing, the challenge that we are facing in it's when you are ignorance. Once you've been diagnosed and you know that you are HIV positive, then you don't want to take it. You ignore, and there is this thing of once your CD4 count is a certain percentage, and once it goes up after the treatments, you want it to not to take your medication again so that you will be sustained by government, by grant, and all those kinds of things. So education is the key.
Okay, so you're elaborating on what Mhlobo and Isaac said about not wanting to accept and being ignorant about it, and you raise also the issue of stigma and how that plays into it, which is really about societal awareness and acceptance. Okay.
Thank you very much. I am Posna Joyce Komamo. Yes, I think they covered all the points, but I also want to emphasize on the point of the education because I'm also working with young people as Vukasana facilitator. They mentioned the point of the substance abuse. Our children and the youth, they start to use the substance at a very early age, from 13 years. And we've got so many people at that age started to use the substance. Meanwhile, also, we also have the children that connected the HIV from the mothers. And therefore, the education is very key. Remember that, again, we are still not comfortable to do the education on the young children at a very early age because of the culture and the religion. And then, therefore, we've got a challenge. Where do we start? Which age group is correct to do the education of sexual and HIV and AIDS? And then we need to still to do more education on parents so that when are pregnant, we can emphasize and make sure that we start to treat about HIV at a very early age. 1, 2. Again, the defaulters, now we've got the children that started to use the treatment, of which they get tired because, again, they were not having the HIV because of themselves and their behaviors, but because they get from the parents. At the age of 13, they start to be tired of the treatment, and therefore they become careless in a way that they put other children on a high risk. Again, in South Africa, especially, I think we still have not enough access of educating people. Because most we focus on the people that are not working. There are people that are working on the restaurant. I never hear the education that is happening in the workplace, in the restaurants, in the constructions, and other places where our people belong. And those people are working 24 hours because of the shifts that they are doing. They still do not have the access to the education. Thank you.
Thank you. So you raised a lot of interesting points, and this issue, which was raised by another group around alcohol, this issue of substance abuse, that obviously feeds into, sometimes, risk of it contracting HIV, and then substance abuse has got its own determinants. Why are people using substances? So, complicated. Right, next group.
Yeah, we are still to add on. We also have a child sexual abuse. Our children are sexually abused at a very early age. You know, in Gauteng, in schools, we find out there's a child who become pregnant at the age of 9. And when we ask what is happening, because that child has not yet menstruated, but they said the fact is that while they engage in sex at the early age, then they become mature early, than that is why they become pregnant. So that is another factor. And also, we spoke about most of the things, or the defaulters, and prostitution. It's also the fact. It's another factor. The upstream, it's when the root cause, we know the root cause, but we are ignorant as South Africans. We know that if you engage in unprotected sex, we teach the children at school about unprotected sex, but still the rate is coming very high. So I think we as PHM and other organizations, we need to start now and engage with from the school levels to say what is supposed to be done.
Okay.
Yeah.
Great. Anyone else in the group want to add anything?
We're divided into two.
Oh, so you're a different group. Ah, okay.
I am Cleopatra from Mamelani and PHM. Most of our things has been already shared, but I saw one point missing. The system itself fails people in terms of if you are HIV positive, it's obviously you have to go to room 17 or 16. And secondly, the green cards, the difference between the cards of people who are HIV positive and people who have CDLs, chronic diseases of lifestyles, are also discriminates towards that. So that's why that resulted to defaulters. And also the language or the attitude of health workers causes patients to default because they are blaming, they are shouting. So there's more other things that have been said. Thank you.
Okay, great. So you've added something else about the response of the health services.
Yeah,
Are you in this group?
Yeah. So yeah, my name is Hafsa. I'm a health committee member in Belleville. They just actually touched on the points that we raised also, the structuring of our healthcare facilities. So once you are diagnosed and you have to go to your public healthcare facility for your treatment, once you step in, it's very easy for people to actually know why you are there, because that is just how our healthcare facilities are structured. You walk in, I can tell you, just recently at our public healthcare facility, we have 4 windows, and nicely the different services for each window are above every window. And I can tell you how patients work out when someone is coming for ARV treatment. That particular window has all these services. Eye screenings, for example, MMC appointments, it's got your ARV treatment, it's got your bank, so, and others. So, yeah, this young lady walks in, she's not male, she's not coming for MMC. She is not pregnant, she's not coming for bank. She doesn't need eye screening.
Bank, by the way, doesn't mean standard bank.
Bank, basic antenatal care, yeah. And she's not coming for an eye appointment, eye screening, so what's left? And that is how people work it out. So you don't even have to...
So it's a stigma issue again.
Yeah, so once again, once people are treated, why are they diagnosed, why are they not going for treatment? That is one of the reasons. It's the structuring of our healthcare facilities, because people can easily identify why you are there. And the other thing is you have millions are spent on condoms and pamphlets and things, and it's put there at our healthcare facilities in a little corner on a table, and no one uses that. In fact, the little children come in, they take handfuls of the condoms, run out, blow it up, and when you have your little streams of water running when it rains, they use it as floating devices. So yeah, so nobody takes it because I think it's too in the eye and too public, and people don't want to take it because they are afraid, for whatever reason, but people will know why they're doing
Some very interesting comments about the health system.
I think everything has been mentioned. I just like that migrant labour is in the centre. I think one of the most upstream problems is poverty, and that's really where our war is. That's all.
So I have 2 points. So Yonela from Stellenbosch. So one of my points also touches on sex work, but not just sex work, but also, with regards to sex work, more the criminalization of sex work. The criminalization of sex work, it perpetuates the spread of HIV. And also because sex work and things like, with regards to sex work and also drug use, because intravenous drug use is a way of transmission of HIV. South Africa does not provide harm reduction services to people who are sex workers, to people who do use drugs. So other upstate countries that do have the resources, they do provide harm reduction services, and we don't. With regards to education, I think the education that we give with regards to sex, there's a language barrier within all our education. If we're not giving it in our mother tongues, are we really understanding? Are we really giving effective education? Also, with regards to education, I feel like the sex education in the country is not comprehensive. I also feel like it doesn't cultivate, because we're talking about the power relations between male, females, older, younger, but do we provide an education, sex education, that cultivates empowerment of women to actually say no? Because once one is comfortable within their sexuality, within their sex, then they're able to say, no, I'm not going to do this. So are we really giving proper sexual education?
Great. So, yeah, okay. So, wonderful reports back. I think you've really covered just about everything. So, this is what we try and do in PHM, and we actually feel that this is an aspect of health which is neglected in South Africa and elsewhere. Oh, you were missed out. Oh, God. Okay, please pass the mic to this group. Yeah.
Okay, so my partner doesn't want to talk, so I'll talk. But I feel like he had some really important points that I think we haven't fully unpacked. So it's been sort of mentioned, but not fully unpacked. And I think it really stems from the history of the country, So I think we mentioned poverty, we mentioned the micro labor system, we mentioned, but I don't think we can really think about why we have this epidemic of HIV without thinking deeply as to the history of the country and the impact of apartheid. So I think we really need to make those links more stronger, and then to unpack it to understand how racism is a determinant of HIV, how gender is a factor as to why there's more women who have HIV, more migrants who have HIV. So I think some of these things are sort of spoken over. The other thing I just wanted to speak about is just reflecting on people's discussions on the determinants of
HIV, there's a lot of talk about people who are ignorant or helpless, or they have information but they don't act on the information. I worry a little bit about how we frame the who's responsible for disease. I think maybe it's something I need to understand, but I'm not so sure that we can. It's so easy to blame individuals. You know, it's these people. They got all the information. They have access. There's condoms there, but they don't use it. You know, I think it's much more complicated. So we use the term stigma, but then where does stigma come from, and why is it there, and why does it influence behaviors that are not even supportive of my own health? Why would I do something that doesn't even help me? You know, so I think that I worry about how we're framing who's responsible for diseases, and to me, it's the framing of the social determinants, because identifying it is easy, but framing it should be considered. It's not individual responsibility. There are structural reasons why people end up behaving in the ways that they do. And those things come from who linked to the systems of oppression and internalized oppression. So I'd like us to think deeper about those things as we go forward and think about determinants of health.
Yeah, I'm covered. Thank you. By everyone. Thank you.
Great. So very important point that Shanaz raises from that group of two about the links between, let's call them intermediate and root causes. Like behaviors are not abstracted from the structural factors which promote such behaviors. So, great. You've covered just about everything, and Louis has written all this up here. Not going to go through it now, but we'll leave this up on the board so people can come and look at it and see how the different causes and causes of causes interlock.
I'll just make one point. I mean, yeah, I couldn't draw all the arrows in everything. But each one of those issues also has causes, as, you know, that you can kind of dig down and find. That's why.
Great. Thanks, Louis, for writing all that up. So I summarized this on one slide, but it's not nearly as rich as all of what you have raised. So starting from the most downstream or proximal or biological, if you like, you know, there's biological vulnerability. You know, women are more vulnerable than men for biological reasons, not just for political and social reasons. Obviously, if you have an STI, you're more vulnerable. Then there are behavioral factors, and you've covered nearly all of those and more. And then there are sociocultural, and some of those have been raised. And then there are the social determinants, like commercial sex, particular vulnerable groups, safety of girls and women, power issues, of course, and then some of the more structural causes, at the center of which, obviously, gender issues and migrant labor. So, in my own view, the fundamental reason why Southern Africa has got twice as high prevalence as any other countries in the world is because of the migrant labor system. and is hardly ever talked about. And by migrant labor, I mean initially to the mines, but later for all sorts of other jobs, mostly in South Africa, but also, of course, in Zimbabwe. The epidemic actually started earlier in Zimbabwe and Botswana than in South Africa, but they all rely very substantially on migrant labor. And migrant labor is actually about cheap labor, because you can pay a Malawian less than you can pay a South African, and actually capitalism is founded on cheap labor. It's more about cheap labor than about capital. So you will see, of course, high structural unemployment in the global north and in South Africa, increasing structural unemployment, but high levels of employment in Bangladesh. Industry shifted to Bangladesh and China and so on, where they pay workers less. So I'm just trying to connect it to the global political economy. So this obviously doesn't include everything that you people have raised. So I'm going quite quickly now because we're well over time. So we can look at other parts of this quadruple burden of disease, these 4 disease epidemics. So let's just take diarrhea in Cape Town, which remains a killer. And between 2008 and 2013, and I should have later figures, but I don't have, but the trend has continued. We've seen a drop in diarrhea deaths. Very good. And this is because treatment has been brought closer to people, because there are now treatment corners in all of the primary care clinics. However, the number of diarrhea cases continues unabated. So you can see in those years, peak numbers in the hot months of the year between about October and April, and that's, of course, because of poor sanitation, water supply, and so on in our townships where poor people live. So healthcare might be improving in the Western Cape, and access is improving, but the causes are not being dealt with. So this is an issue we keep hammering as PHM. And unfortunately, in most health policy discourse, not talked about very much. So again, I'm not going to go through this, but you can do the same exercise for child health problems, going from the more downstream or biological all the way up to structural things like neoliberal policies, where actually, although wealth increases on an aggregate level in the country, poverty for the poor remains untouched, and the inequality gap just increases within South Africa and globally. So we're not going into that, but if you read Global Health Watch or you talk to some of us, we can talk at great length about the global political economy. So under 5 mortality in South Africa, young kids, 4 times as high in the poorest compared to the richest. There's obviously a race dimension. There's a huge overlap between race and socioeconomic class. And of course, maternal education, rural, urban, and so on. You can see the huge inequalities and causes thereof. And with the problem of nutrition, which underlies a lot of these child health problems, unfortunately, when we compare, for example, data from 2005 with 2012, the number of children who are stunted, too short for their age, which means chronic undernutrition, unchanged. In fact, probably increased a bit. And this is because, not the only reason, but at least a quarter of South Africans experience significant hunger at some time. And that's not because there's not enough food in the country. There's enough food in the country. We're not a country where there's famine. So poverty fundamentally underlies these problems. 6 out of every 10 children in South Africa live in extremely poor households. Of course, most of these children are black African, not only, but most. And so poverty, and we would say in PHM, the causes of poverty underpin most of these problems. And by the way, as you said with HIV, it's not just poverty that drives HIV, it's inequality. The rich sugar daddies, or richer sugar daddies, and the poorer girls. So this just looks at South Africa's unemployment rate from 2010 to almost the present, and you can see it's going up and up and up. And the number of people who've ceased looking for employment has gone up to over a quarter, almost 30%. So, when you learn about nutrition at medical school or nursing school or wherever, it will be depoliticized. But it's actually a political issue, as are most health problems. So, almost finally, we also have an epidemic of NCDs. Actually, NCDs are now even bigger than HIV as a problem. So these are the ones, I mentioned them before. These are the NCDs that people are dying of. And just to take diabetes as a case example, these are data from Western Cape. The light bars are 2008, and the dark bars are, the light bars are 1990, and the dark bars are 2008, 2009. In other words, an 18-year gap. Not exactly the same people, but in the same areas. And you can see that in the older age groups in particular, the prevalence of diabetes has gone up 3 times, threefold. So over a third of older people in the Western Cape have actually got diabetes. So this is a huge problem, huge, huge, huge and expensive problem for the health sector, but also a very disabling problem for those people who got diabetes. And why is it happening? Well, it's associated very strongly with obesity, and that arrow is pointing to levels of obesity in females. They've also gone up in males, but more in females. So you see in the over 45-year age group, more than 50% of women are very overweight. And this predisposes to diabetes. So again, it's not just a behavioral problem, as Shanaz reminds us. It's a problem of what people are eating and why they're eating what they're eating. So this is the evolution of humanity. It's where we are. And these are the behavioral factors. That we have a very high sugar and fat intake in South Africa, that South Africans consume about 3 times the global average of Coca-Cola products. There are cultural and behavioral issues, like people, at least recently, didn't want to be thin and lose weight because they'd be thought to have HIV. And then there's so-called modernization with the promotion of modern foods like KFC and so on, which are contributing to this problem. But actually, the biggest underlying factors are structural, and they're to do with what the economists call concentration, we would call monopoly, in the food system, from land and seed all the way through processing, manufacturing, retail, and advertising, concentrated under the control of fewer and fewer companies like Nestle. And the other big ones in South Africa are Tiger Brands, Cadbury, PepsiCo, Parmalat, and so on. There are about 10 that control our food system. So I end now to transition into Leslie. So we've talked very sketchily about what we call the social determinants of health, which are actually social, economic, and political determinants of health. Social, cultural, economic, and political. They have to do with power and money, ultimately. Power and money. But obviously the health system is also a determinant of health. So just very quickly, and I think Leslie will go into it, we have, as you know, two health systems in this country, the private and the public. These figures are a little out of date, but you can just see that those people who use the private sector only in 2009 were costing 11,300 Rand per person per year. And those who use the public sector, less than 2,000 per year was being spent on their health care. Leslie will talk about whose money this really is. Is it really people paying out of their own pockets, or is it more complicated? And just very finally, actually, even the public healthcare services are used more by the richest 20%. So here you have something called the inverse care law. Those people who most need the services use them least. Of course, that disparity is much steeper in the private sector. You'd expect the richest to be using the private much more, but even the public is used more by the richest. So, the key challenges, and here's where I stop. The burden of disease due to the social determinants, failure to realize community participation. I think Leslie will touch on this, or we'll certainly deal with it as a theme later on. A crisis in human resources for health. We're going to talk about that in one of the themes today. Lots of managers, too little leadership. Our programs aren't coping with HIV and TB. And privatization, we would say, is no answer. And the whole purpose of this and of PHM is try and revitalize, re-strengthen civil society. Because we have a big civil society in health in this country, but most of it is service delivery NGOs who are not talking politics. Okay, I'll stop there.